it's just a huge, huge honor for me today to be podcast interviewing Randolph Richard Resnik, DMD, MDS. He is a leading clinician, educator, researcher, and author in the field of prosthodontics and oral implantology. Dr. Resnik received his dental degree from the University of Pittsburgh School of Dental Medicine. Upon graduating from dental school, he continued his training at the university and received a specialty degree in prosthodontics. He then furthered his postgraduate education at the University of Pittsburgh by completing a fellowship in oral implantology while also earning a master's degree for his research on dental implants. He has spent the last 30 years working alongside Dr. Carl Misch, serving as surgical director of the Misch International Implant Institute and chief of staff. During that time, Dr. Resnik established himself as one of the world's experts in dental implant radiology while also continuing to improve educational protocols in implant dentistry through the Misch Institute. Dr. Resnik serves on faculty positions at numerous universities, including the University of Pittsburgh, Temple, and Allegheny General Hospital in Pittsburgh. Along with his passion for lecturing and education, Dr. Resnik is also an accomplished author, having published numerous research articles across his career. His recent textbook, Avoiding Complications in Oral Implantology, is a bestseller. He has also been a contributing author to all 3 editions of Contemporary Implant Dentistry and 2 editions of Dental Implant Prosthetics. I'll tell you what, this book was so show me the Endo book too. I'll show you the 2 best books I read last year, it was Pathways to the Pulp by Stephen Cohn. It was like his 11th edition, and we had him on the show. And Misch's Avoiding Complications in Oral Implantology by Randolph Richard Resnik and the late Carl E. Misch. What I loved about this is, do you remember the late prosthodontist who I think his final days were at Green Laboratory in Arkansas?
Charlie English. Charlie
English.
Yes.
What I loved about this book so much was Charlie was the only one who had so much self-esteem. He says, these guys that teach implants or veneers or bleaching bonding, they go around the whole world with the same 10 cases that they did 100 million years ago, and they're almost lecturing for their own self-esteem. He said, I'm going to show you every dental mistake I ever made, every screw up, every lawsuit, he called them dental abortions. and you learn, because his deal was that if you do something and it's predictably and it's repeatable and every time you do the same, he says, you don't learn anything. He says you only learn when something fails, because if you just do something the same recipe every time, and it never fails, you don't even know what's going on. And that's what you guys did. You and Carl, Avoiding Complications in Oral Implantology. My God, it's 864 pages of everything that can go wrong, could go wrong. I mean, it was like reading Beethoven. I mean, really, congratulations on that. And then it's just a huge, huge honor that you came on the show today. How are you doing today?
Great.
So, so how is the Misch Institute doing now that the Carl's passed on?
Actually, we're doing great. We just had a complications course in Miami last week. We had over 100 for that, which is the second course we've given this year. So it's going very well. Our surgical programs actually sold out for Orlando this year. So we're doing great. Very well.
I was in Orlando last week for the towning meeting, and I kept saying if I found an hour, I was going to jump on an Uber and run over there and surprise visit you. But I love Orlando.
Yes.
You like living down there instead of Pittsburgh?
Well, no, I don't live there. We just give the courses in Orlando, and the other spot is Vegas now. So we give them in Orlando and Vegas, and then sometimes we'll stray and do like a complications or a CT course in another city like Miami or Arizona, somewhere like that.
So your book is available on Amazon. It only has 5-star reviews. You don't even have a single 4-star review. And you can also let's see, do they have it? Well, you can get it next day. You can get it same day. But you can buy it new, and you could also buy used ones that are very good. How's that?
Wow.
You can buy
Okay.
new or used.
Didn't know that.
And so the mission suit's doing well,
Yes.
and
Yes.
you're selling out.
Yes, we are. Yes.
Yeah. So talk about the mission suit. Is that so? Is it like when I did it? I got my fellowship in the mission suit, and that's when I earned my diplomat in the International Congress of
Yeah.
Implantology. It
That
was,
was back in the late 90s or
I actually took the course with Fred Flintstone, and that's how. But back then it was 7 3-day weekends at the
yeah.
University of Pittsburgh. So
Yes.
what does that look like today? Is it 7
Okay.
3-day weekends, or is it
Now
4 days?
6 2-day programs. So
So I
what
got
we
gypped then. I had to take 7 3-day, and now you're doing it faster, easier, higher quality, lower price. So
yeah.
you've really improved.
Well, it's funny when the early days of the institute, we would end the institute lectures on Sunday at 6 p.m. And then people were having trouble with flights, and then we started ending at 1 o'clock. Then we decided, well, let's try to do it in 2 days. And what we found was we do 2 9 or 10-hour days, and doctors like it more. Some leave Saturday night, some leave early Sunday morning, but now they're able to get back to their office for Monday. So it works out pretty well.
You know what my favorite memory of I have so many amazing memories of the 7 3-day weekends. The first was, I was placing these implants, and, and you're all scared, and you're laying a little flap, and you're doing all this. And then you go down and watch you guys, and I mean, there you were doing retromolar pad to retromolar pad, placing, 8 implants in the lower, 8 in the upper in like 30 minutes. And I told everybody, I said, it's kind of like you're at home with this 22 rifle, and you're afraid of it, and you're scary, and you're trying to upgrade to a 12 gauge shotgun. And then you go to war. You just go to implant war, and it's just blood and guts. I mean, it was like you were just so numb that then when you went back and you're placing your little dinky implant in a first molar or a maxillary second bicuspid, I mean, you almost felt embarrassed. You hope no one was looking at your little. It was like going fishing and catching a minnow, and you guys were just hauling in whales all day long. So it was really, really amazing. And then the other high point was, you'll never guess this story, Ryan. Well, when you go through a curriculum, 7 3-day weekends with the same bunch of guys and gals, it kind of turns into a fraternity party. And I think it was like the 5th or 6th one or whatever. I heard that Kiss concert was that night. So we somehow all got tickets, but after the course, we went and saw Kiss in Pittsburgh, and that was one of the craziest, funnest nights ever to go rocking out with Kiss with about 20. that was so much fun. So basically, 25% of everyone listening to you today right now is in dental school. The rest are all under 30. I get like 1 email a week. Send me an email, howard@dentaltown.com. Tell me how old you are, what country you live in, if you like the show, if you hate the show, who you want to hear on, whatever. And they're all going to say the same thing. They're going to say, Randy, I just graduated from dental school. I didn't place 1 implant. So it's easy for Randy to go from placing his 10,000th implant to 10,001, but how do you coach a kid coming out of dental school to place? How do you go from 0 to 1? Walk them through that.
Well, I'll tell you, we've changed the curriculum to now where we start with basically extracting the tooth, determining if it's a 4 or 5 well defect, grafting it, taking a CT scan, treatment planning that area with a CT scan, and then determining whether to do the surgery guided or freehand. Then we go into multiple implants, so a multiple edentulous site, and then we only go into edentulous or fully edentulous patients. So it's changed a little bit from when you went through. Now we start with basically the Division A patient, which means that there is abundant width of bone, abundant height of bone and no vital structures in the area. So basically, we take small steps and then we gradually get into the more complex cases. Now, back when you went, some people would start with a subperiosteal implant or start with 8 in the maxilla or a sinus lift.
Dude, when I was doing it, there were still Ramus frames.
Yes. And so we now take it a Division A weekend, which is, again, abundant bone. Then we go to Division B, where there is a minimal amount of width, and you have to build up the bone in width, so you make it Division A. So we take small steps, and it's interesting you said about the young doctors. We actually, this year, we have GPR residents that are actually taking our course. And we do see younger and younger doctors coming in, which is, back when you went, most of the doctors were established and had large practices, but now we're seeing them right out of dental school, which is great.
They're driving to work right now, so they can't take notes or anything. We always do a transcript of every one of our podcasts and put on Dental Town where we post podcasts, but I always retweet. You guys are at Misch Institute. Okay, I just retweeted you. Thanks for following me at Howard Farran. It's an honor that 25,000 of you follow me. So how much? So it's 6 2-day weekends. So how much would 6 2-day weekends cost? How much would the whole kit and caboodle cost if someone came in? And at what time period would they do? Would you recommend they do all that in a year? Would you space it out over 2 years? How would you? What would you recommend their journey be?
Okay, interesting. When you went through, everyone started at what we called S1, then went to S2, all the way up to 6 or 7 weekends. We still have the S1, 2, 3, up to basically S6. But what we have done is we have made it to allow doctors to come in basically if they want to start at S3, S4. Like, for instance, we'll get some specialists who will just want to come in for S4, which is a sinus grafting weekend. Someone who's early on their learning curve is going to want to start at S1. The interesting thing is no matter where doctors start, they usually end up taking the whole curriculum, which is the 6 or 7 courses. And we have 2 programs, one on the East Coast, which is in Orlando, and then one on the West Coast, which is in Las Vegas.
And which one's more popular with dentists? Because basically 75% of America lives east of the Mississippi River, and 25% lives west. So which course is more popular and sells out faster?
You know what? They're both very, very popular. This year in Orlando, we were sold out rather quick. We can only take about 70 doctors because of our hands-on program, and it's so detailed, the laboratory programs. And that sold out rather quick this year. A lot of people from the East Coast like to go to Vegas. So we get a lot of people from the East Coast who would rather travel to Vegas. So to be honest, they're both very, very popular.
Right on. So so another thing that I think that's very bizarre about implantology is, what is it? Clear Choice is the dental implant. Can you give me the link to Clear Choice? Are you very familiar with Clear Choice, or do you work with them much? But everybody keeps talking about Allon4 at 25,000 an arch. But in my walnut brain, what I mostly see the big money, and I found huge money in this with a lot of my graduates that I went through the Misch Institute with. They would go back to their town, and in their town, in the poorest part of town, was this like denture world that had been there for like 40, 50 years, and they had a lab tech, and they were doing, upper and lower dentures for $4.99, and these things would be for sale for like $350,000, and nobody would want it. They'd all want to go to Beverly Hills and Scottsdale and Key Biscayne and do dentistry on lifestyles of the rich and famous. And these guys would buy that little denture world that had a brand name and all these reoccurring seniors always coming in to get a reline and get new dentures. And then they would go add the implant. They'd start upgrading. They'd say, well, yeah, that denture is upper and lower $4.99, but we have a better one that's $9.99 with these really beautiful upgraded Ivoclar teeth, and they're a little prettier. And then for $29.99, we'll just put two little ball and sockets down there, and then for and they had it all the way up to a $25,000 arch Allon4. And they would go in there and they would start placing 100 implants a month, and this little thing doing $350,000 a year was now a $3 to $4 million business, because it was kind of like adding peanut butter to chocolate. They came out with silent films in 1891, and it took 40 years before one person decided to add the phonograph to it and take it from a silent movie to a movie with sound. So it took 40 years to see that. And I'm telling you guys out there, don't take 40 years to see that Goldmine. Those in every major town, there's this little denture world there. And and the best DSO that's got this figured out is actually Aspen. Aspen has a denture lab in every one of their locations. And do you know many dentists who did that in their career?
Oh, definitely. And you're 100% right. The other thing, Howard, that when you're talking, everyone wants to do Allon4 now. And part of the complications, if you look in the textbook in this past weekend, I do a lot of lecturing on the Allon4 technique and not giving these patients all the treatment options. I mean, if you look at almost every state board now in the country, you're obligated to give every patient every option. So that could be a denture, that could be a overdenture. You remember there's two overdentures, RP4, RP5, or it could be an FP3, a fixed prosthesis. So it's interesting when you say that, you have a patient who's been in a denture for a long period of time. I can't tell you how many patients come in and say, you start with two implants, then they upgrade it to a, fully implant-supported overdenture, then they upgrade it to a fixed prosthesis. So, but you're 100% right. Those practices, I've seen so many people flourish with those type of practices.
Ryan, can we just name this podcast? Dr. Randolph Resnik said Dr. Howard Farran was 100% right. I just want to name the whole show after that. Can you hand me that? Do you know my only claim to fame in dental implantology?
What's that?
I'm the only person who ever placed an implant underwater.
Underwater?
Yeah, I had this bottle of water on my head during the whole procedure. So I'm the only human on earth who placed an implant underwater.
I like that.
Yeah, that's my only claim to fame. You just wrote a textbook. I did an implant underwater. But but back to business. Because what I married in my career was a dental degree from UMKC with an MBA from ASU, and everybody talks about this Allon4, but for how many Allon4 cases are done how many Allon-none cases are done every day for an Allon4? What do you think that ratio is?
It's so hard. I tell you, now it's going to Allon3. I don't know if you.
But again, let's go with Allon-none. An Allon-none is a denture. I don't know. I don't have any stats, but I'm thinking there's 100 dentures made for every Allon4 done. Would you agree with that? It's 100 to 1?
Yeah, probably.
And your journey of what you said, that first you take that Allon-none and you upgrade it to Allon2. And then they get it. So then a couple of years later, they sit there. They want to fully, Allon4 ball and socket. And then eventually they want it fixed and they want it to come out. So the mind is a journey, and it's not just dental health. it's mental health. And the first, they don't like the denture because, in fact, most people don't even complain about the chewing efficiency of the denture. It's the psychological, it's the mental deal. Well, what's wrong? Well, I'm afraid to laugh. I was at a party the other night, it slipped. It seems like they have more emotional trauma. I've had several ladies tell me that the reason they went to fixed with a perfectly fine denture is because they can't sleep with it in their mouth at night, and their husband has never seen them without their teeth out. And then the saddest one I ever did, and when she told me this, I literally, I almost had to take a knee and cry. You know what she told me? She was like 80 years old, and she had a perfectly fine denture, but she couldn't sleep with them in. And she told me that her friends, her three best buddies now have all died, and they all died in her sleep. And she didn't want the paramedics to come in her room and find her dead in her bed without her teeth. And this lady got, back in the day, it was 6 implants on lower and upper. So I did 6 implants so that some hillbilly paramedic doesn't find her without her teeth. I mean, I'm a man. If you found me dead on bed, you fully have permission to throw me in the Arkansas River and feed me to the turtles. I don't believe in putting yourself in an aluminum casket. I think that's pollution. I don't think it's fair to cremate someone and just turn you into heat radiation. I think I like the recycle thing. I tell my boys, dig a hole 6 feet, throw my ass in there, populate with a couple of maggots, and I'm done. But I couldn't believe she was paying me all that money so that no one would find her dead in her bed without her teeth. So it's all on none. So when you upgrade that to all on 2, what type of implant would you do? Would that be ball and socket? What?
Yeah, I mean, the most popular now is locators or O-ring type of attachments.
And
probably
what brand?
When you went through, we did a lot of O-rings back then, which is a great attachment.
And what brands?
Either BioHorizons. Now we're using the Hahn implant from Glidewell.
And that's what I love about Jim Glidewell. You know who Jim Glidewell reminds me of?
Who's that?
Well, I mean, when I got out of school, I went down the Pank Institute, and they're telling me how there's A patients, B patients, C patients, and you want to just hang out with. And they were describing how you want to just network with the A patients. And when he described the A, B, C, and D, I raised my hand and said, "Well, the entire Farran family out of Parsons, Kansas, we're all D patients. I mean, I'm not that dentist. I didn't go to Scottsdale. I went to Phoenix. I went to D patients." And what I loved about Herb Kelleher, and all the dentists were talking about, they'd always throw Glidewell under a bus. It was like they'd make fun of you if you used Glidewell. And then they'd recommend these labs that were like $350 a unit. And then I watched Herb Kelleher go out there and focus on cost. The only secret to lower prices is lower cost. And he focused on cost so much that he gave so many Americans the freedom to afford to fly, to go to their grandchildren's baptism or bat mitzvah or birthday or whatever. And Jim Glidewell, good Irishman, he just squeezed every single cost he could out of there. And the quality, I think, is amazing. And he's given so many Americans the freedom to fix their teeth. And when dentists take their, you should have, my dad always told me, you have one eye on your customer and you have one eye on cost, and you use your God-given talent to drive down costs so your customers can afford to buy what you have. And I took big notice when Jim Glidewell latched onto that Jack Hahn system. So talk about Jack Hahn and Glidewell.
Well, Howard, what we had a problem probably starting about 10 years ago where we started seeing doctors coming through our program. They would pay for this whole curriculum, and then to outfit their office to surgically place implants, it was cost prohibitive. By the time they got a motor system, stocked their office with implants, it was very, very costly. A lot of these doctors are associates, and it wasn't working out too well. Jack Hahn, who's an amazing individual, one of Carl's closest friends.
Out of Ohio?
Yes, out of Cincinnati, took the replace implant, which he designed over at Noble Biocare, and he took it over to Glidewell, made it platform switching, and then they made it so ideal for the starting practitioner cost-wise, it was perfect. So our doctors now can get a motor, they can get 35 implants, they can get a surgery kit, a prosthetic kit for $6,000. 10 years ago, the motor that they were buying was $6,000. So now these doctors can get in at a very low fee, and then they send the case to Glidewell for the prosthetics, and Glidewell's already very inexpensive, but they give them 20% off on that. So it was a win-win situation. It's a great implant, and it's a great company to work for. I mean, if you look at any of the R&D now on lab materials, they have a monopoly on it. I mean, monolithic zirconia, they developed it. Most labs buy their lab supplies from Glidewell now.
Oh, so, I got to tell you, I'll tell you a Glidewell story that'll blow your mind. So when I first went to China, labs were very labor intensive. And we went to these big labs like Modern Dental. They'd have like 4,000 techs, and every hour a UPS truck would come up. And I noticed that all these crowns were from all these little small labs from around the United States who were telling their doctors, I'm making everything. And they were probably making some, but they were packing up the majority and sending them to China. And I talked to a lot of them. A lot of them said, well, dude, look, I've had an ad in the paper for a model trimmer, die trimmer, porcelain deal. The dental schools quit teaching lab techs. Imagine if all the dental schools quit teaching hygiene. Where would you have a hygienist? So all the dental schools closed down their certified dental laboratory deals. There was no labor, so they're all sending them to China. Fast forward 10 years, the CADCAM, the digital making at Glidewell. You go back 10 years now, it was silly. The labs were sending it to China, and for China it was cheaper to ship them back to Glidewell, because Glidewell. And this is what Jim told me. He said when I started, I would hire 5 people, and it would take me a year to bring them up to speed, to pour up a model, trim a die, wax a coating, cast it, put it on, stack the porcelain, bake it. And after about a year's training, they could do 5 a day. Now with CADCAM, I can hire 5 people on Monday, and by Friday they're completely trained and they can make 50 a day. So it didn't matter that China had low-cost labor. These people were making 5 a day. Now Jim could take that same person and make 50 a day. So now crowns are going from labs in America to China, and then they're being shipped back to Jim, and then Jim ships them back to China, then China sends them back to the lab. I mean, the whole world's, it's just a crazy world. But you tell Jack Hand, he's missing the obvious. He's from Cincinnati. He's got that $6,000 kit, a motor, 35 implants. He's in Cincinnati, the Rock and Roll Hall of Fame. You should throw in 2 tickets to the yearly Rock and Roll Hall of Fame, which will be on HBO May 8th. It's my favorite show of the year. They always have the Rock and Roll Hall of Fame. But HBO doesn't carry it live. But that is my favorite show every year.
Oh, wow.
On HBO, the Rock and Roll Hall of Fame. Tell Jack if he threw in 2 tickets to the Rock and Roll Hall of Fame, he would increase his sales a gazillion %.
I will do that. I will do that.
And tell Jack to come on the show. I would like to hear that story. So the Han system and the BioHorizon system out of Alabama would have the 2 locators or the O-rings. You like locators now, not O-rings?
Yeah, I mean, either one. I think O-rings are still easier to use, but, the profession really has gone towards locators as the number one attachment.
And then you say they start with 2, and then after a while, how long does it usually take, you think, before Grandma and Grandpa upgrade to 4 locators?
Well, the way that we teach it, the way that we teach this is we place implants in particular areas for a reason. So like in the mandible, between the foramens, we divide up into A, B, C, D, E, 5 positions. So usually like for 2 implants, we'll do B in the D position. Then it might be a year. I've had them 6 months later come back and say, you know what, this is great, but I don't want to come out. So all that we do is go back, and because we put them in the B and D positions, now we put them in ACE, And now it's 5 implants, and
the A, B, C, D, E is all anterior to the mental foramen.
Yes.
And how forward to the mental foramen do you like that to be to miss the mental foramen, the anterior loop?
So what we do is we start our first osteotomy in the A on the right side, E on the left, 5 millimeters from the most anterior part of the mental foramen. That will allow a 2 millimeter safety zone for a 4 or 4.5 millimeter implant. So we always want to be 2 millimeters away. To determine if there's an anterior loop, what we'll do is look on the CT scan and look in the axial plane. It's a step-by-step in the textbook on how to do that. The anterior loops can be, most are less than 1 millimeter, but there can be some up to 6 millimeters. So you have to be very careful.
And is doing this with a CBCT? Do you think America has 1 million attorneys? If you hit that anterior loop and you had a pano, is CBCT, is that the legal standard of care? Do you think?
Yeah, Carl and I used to go back and forth on this. And back when we were residents. Carl and I were residents together in Prost, and he selected a different master's topic with force-related biomechanic issues, and he thought I should do the same. I picked CT scans, and that was back in the late 1980s. I'll never forget there was a MD radiologist on my committee, and he turned to me and he said, CTs will never come into dentistry. They're too expensive, too much radiation, this and that. Now, when we have a course, I'll ask our course attendees, how many people have CT scans? I'm going to say 85% have CT scans. So your question was, has it become standard of care? Carl never thought it would, but I have to say I do believe it has become standard of care. If you look at some of the studies on nerve impairments, there's one study that shows 10% of nerve impairments, a CT scan was not used. A couple other studies show about 50% of nerve impairment cases had inadequate radiographic assessments. So it is basically become standard of care.
And what CT scan, do you have any favorites?
Yes. So Carl and I both, when he was practicing, it was an ICAT, and I have an ICAT also, which ICAT's top of the line.
The bottom line is, whenever you meet someone who's placed 5,000 implants or more, they always got ICAT. It's like they kind of own the oral surgeons, the super producer, the super implant user, oral surgeons, and periodontists always have ICATs. Why is that?
It's just the best CBCT unit for many, many reasons. Number one, you can collimate it. So you don't have to take a full field of view on a patient if you're doing a sinus graft and you just want to look at it postoperatively, or if you're looking at a number 19 edentulous site. So you can collimate it to decrease the field of view. Two, it is very, very accurate. It's 1-to-1. A lot of the generic CBCT units now in the market, you have to be very, very careful. They have a smaller sensor size, but then they'll take a larger picture, so they'll actually take it on more of an angle, where ICAT is definitely 1-to-1, so meaning whatever you measure on the image, you're going to see clinically.
So who were the superheroes that already had X-ray vision? Because you wouldn't need an ICAT if you could actually hire. Who was it? Was it Superman? Who had X-ray vision, Ryan? It was Superman? So unless you're Superman with X-ray vision, you're recommending a CBCT, and you'd recommend iTero.
ICAT.
I mean iCat. iTero was bought by Align, who owns Invisalign. So so you like iCat, and how much are those costing today?
I believe they go anywhere from about maybe $85,000 all the way up to a full field of view, which is probably about $140,000.
And they're not trying very hard to sell. I noticed their last Twitter tweet was September 14th last year. You can follow them at ICAT3D. So you should call your buddies at ICAT and say, dude, you should send out more than one tweet every 6 months if they want to sell. But they're selling word of mouth.
Yeah, believe it or not, their biggest sales are to orthodontists now.
Really?
Orthodontists are all buying. The iCat has a full field of view, so it's perfect for orthodontics. The amount of radiation is very, very low. So it's a perfect scenario for an orthodontist.
So for the CBCT, you like iCat. For the implants, you like Glidewell's Jack Hahn system or Alabama's BioHorizon, which, by the way, when you go down there, Alabama, that area, they made the solid rocket fuel boosters for the shuttle. I mean, it's like a miniature Silicon Valley up there in Alabama, isn't it?
Wow, I haven't been there in a while.
Oh my God! I mean, you think of Alabama, you just think, just country. It's a country state or whatever. Oh my God, it's so high tech. So I'm again trying to hold your feet to the fire for the young kids under 30, trying to go from 0 to 1. Another big confusing thing they did is they never got to place an implant in dental school. Ryan and I had dinner the other night with two recent grads from dental school. One had graduated and $400,000 debt and never did one root canal, and the other person did one. Can you imagine that? I did 15 root canals in dental school, and can you imagine paying $400,000 to become a dentist and you didn't even get to do a root canal? So obviously they haven't placed an implant. But in their lectures, they're just told over and over and over about the health history. They can't be smokers, they can't be alcoholics, drinkers, diabetics. Well, your yoga instructor usually isn't the one that needs implants. When they come into my office from Phoenix losing their teeth, they're usually drunk Irish, smoking, drinking. Probably had their last vegetable was beanie weenies. So how do you start doing all these implant cases when the people that are most likely to lose all their teeth, in Apache Junction up the street, it's from meth. You didn't meet that patient at Lifetime Fitness. So review the health history, because everybody in her town that needs an implant isn't going to pass the health history. So what I did, if you look at the complications book, I wrote that chapter with my brother, who's an internist. And what we looked at is basically all the systemic diseases and a lot of the medications that affect implants. And what people don't realize is every disorder, let's say diabetes. Diabetes can be no contraindication at all, or it could be an absolute contraindication. If they have an A1C of 10, you certainly don't want to be putting an implant in them. But if they're a diet-controlled diabetic, there's no problem at all. So what you have to do is look at any positive findings on the medical history, but then ask the question, do you smoke? How much do you smoke? Etc. Do you drink? How much do you drink per day? I told you they were Irish.
Yes.
They smoke and drink every day.
Yeah. So smoking and drinking is not a absolute contraindication in most cases. In a lot they are. Part of our complications course that we just gave this past week in Miami, we have Frank DeLuca, who is a dentist and an attorney, and he comes in and he talks about the medical history, how important it is. You'd be surprised how many people don't even get the medical history taken, but they don't even look at it or ask the patient any further questions, which is very problematic.
So another thing that scares them is, again, who are these people that are losing all these teeth? A lot of them had periodontal disease. And then these kids are reading that, that after 5 years, 20% of implants have PeriImplantitis. And there's some studies that are showing that at 9 to 14 years, over half of the implants have PeriImplantitis. So what's your thoughts on PeriImplantitis?
Well, PeriImplantitis is definitely an issue. If you look at the etiology of it, basically the same bacteria that causes periodontal disease in natural teeth cause PeriImplantitis with implants. Therefore, you have to be very, very careful, even placing implants in someone with active periodontal disease. But a lot of the periimplantitis is caused from implant positioning or treatment planning. If you don't put the implant in the right position, if you put it at the wrong angle, the prosthesis has to be compromised, and then the patient can't clean it, et cetera, and then you end up with periimplantitis. But it is a problem. And treatment planning is huge in implantology. And unfortunately, dental students don't get that. And that's why our course is so popular, because everything is about treatment planning to get you out of trouble, prevent you from getting into trouble. So when you look at that complications book, the reason why we wrote that is for doctors to understand how to avoid getting into that complication. It's a lot easier to avoid it than to get into the complication, not know how to get out of it.
So some of them are hearing that a great way to treat periimplantitis is buying a $85,000 Millennium Dental Laser, who started off with a LANAP protocol, laser-assisted new attachment procedure, and now they have an implant protocol. Do you think that that's worth the investment at $84,000 to treat periimplantitis with a laser?
To be honest with you, I don't have a lot of experience with the laser. Studies are kind of all over the place on that, and I'm more the conventional, flap it if it needs it, detoxify the implant, and I really haven't I really don't have a lot of experience with the LANAP or anything like that.
Oh, and Ryan wanted to know on that health history. I don't know why he keeps asking me. He wanted to know on that health history if erectile dysfunction was a contraindication for implants. He says he's asking for a friend.
Oh, okay.
So what's your answer to Ryan? Is ED an issue?
I think you should answer that one.
Ryan, we'll talk after the show, buddy. We'll talk after the show. There's also people on the circuit today saying that that this medical grade titanium really isn't all that medical grade, that it's a heavy metal, there's a lot of titanium ions, it's causing inflammation, and that they're seeing less periimplantitis with ceramic dental implants. And you see some of the major companies like Straumann buying ceramic implant companies. Do you think ceramic implants are going to have less periimplantitis than titanium?
The interesting thing about titanium implants, back when you went through the Institute, we would always talk about commercially pure titanium, which most of the implants were back then. You'd never have a reaction to those. There wouldn't be any tissue. It was biocompatible, the ideal material. And then they made 6-4 titanium. And in dentistry, you're starting to see a lot of articles, case studies starting to pop up about allergies. And if you look in, I have a couple in the textbook where implants have been placed, hypersensitivity reaction, and until they're removed, that doesn't resolve itself. So there is definitely, I think, in the future, a role for ceramic implants. The problem is right now, the question is how long, the longevity of the implants and the fracture problem that they do have. Not only the fracture of the implant, but the fracture of the abutment that goes into the implant.
There's just a few world-class dental implant companies, but one of the biggest ones in the world is Zimmer Biomet, and I read in the Wall Street Journal that they've retained Bank of America and Merrill Lynch, and they want to spin off Zimmer Biomet Dental. They want to sell it away. Why do you think one of the biggest implant companies, they make hips, knees, spine, most of the dental implant companies, they just make dental implants. Zimmer makes every prosthetic component that could be implanted in the human body. So why do you think they would be spinning that off?
I have no idea, but implants, if you look at the projections on implantology, It's been one of the fastest growing areas in medicine, and it's shown to become continually a growing business. If you look at exposure in different countries, the United States, there's still about 15% of patients who need dental implants have been treated with dental implants. And then you look at a country like Israel, where it's almost 50% have been treated. So we're still, it's a treatment plan that has not been 100% accepted yet, but I believe in the younger dentists coming out, they're going to have no choice but to get involved with dental implants.
Yeah, I love the Wall Street boys the most because they don't have any emotional dogs in this game. They just read the numbers. And whenever they're talking about implants or like Invisalign, Line Tech that owns Invisalign, they just say the number of people that will eventually get Invisalign. I mean, that market is just growing so fast. I mean, when we were little, you had to have a malocclusion so bad that your mom didn't think you'd ever get married. Before the one kid, all these big families back then. I think in 1945, average American family had over 5.5 kids. Now it's down to basically under 2. And but now they're coming in to get Invisalign just because they got this little crooked thing right here. And same thing with implants. I mean, the implant placement rate in Israel, South Korea, and Germany, not only is it several times higher in the United States, but what's also the most mind-blowing is that in South Korea and Germany and Israel, 3 out of every 4 dentists surgically placed an implant last month. And America's light years from that. I mean, why do you think in South Korea and Germany and Israel, 3 out of 4 general dentists placed an implant last month, and in America, what do you think it is in America? Out of 125,000, so there's 211,000 Americans who have an active license to practice dentistry. 150,000 are general dentists, 32 hours a week or more. 30,000 are specialists, 32 hours a week or more. Of those 125,000 dentists, 32 hours a week or more, what percent of them do you think placed an implant last month?
Well, if you look at the statistics, 1999, there was a study showed 7% of general dentists surgically placed an implant. In 2015, which is the last study that I have seen, it's around 15%.
15%. And when I'm talking Germany, South Korea, and Israel, I'm talking 3 out of 4 placed one last month, not ever placed one in their lifetime. I mean, placed one last month.
So if you look at the statistics in Europe, 90% of dental implants are placed by general dentists. So say
that again.
About 90% of implants are placed by general dentists in Europe. So if you look at the United States, it's been a specialty-driven, implants have been specialty-driven for many years. The early days of the Institute were mainly specialists taking it. Now it's almost 100% of our attendees are general dentists. So I think that's going to change dramatically with the costs coming down, with the easeability of placing implants and the education out there. I believe that the general dentists are going to be doing a lot more of the implants and definitely taking over the specialty there.
And the other thing, these young kids come out of school and they, I really feel they're misguided when they say they want to go to Beverly Hills and Scottsdale and Key Biscayne and be a cosmetic dentist and get into bleaching, bonding veneers. And I'm like, dude, the people that make the most money are oral surgeons, extracting teeth and placing implants at $411,000 a year on average. And I know several that take home $800,000 a year more. And next up at bat is these endodontists at $374,000 a year doing molar root canals. And what's neat about that is you have to sell veneers, and you got to have the look. If you notice, all the people crushing it, selling boob jobs and tummy tucks, they look like Bill Dorfman, who's a TV star. Yeah. They're sexy and they're got a six-pack and all that stuff, and it's part of the pizzazz. And then you show me some guy that looks like Fred Flintstone after he fell off the beer wagon, and he thinks he's going to do that in Salina, Kansas. And I'm like, dude, it's not going to happen. But all those people are going to come in with pain and want those wisdom teeth or that tooth extracted. They're going to want them replaced with implants, and they come in with a toothache, and you do the root canal. And I say, you got to get into oral surgery. You got to extract teeth, place implants, do root canals. If you can do oral surgery and endo, you're gonna pay back your student loans, and you're gonna do fine. And they say to me, they go, well, I don't like molar endo. And it's like, dude, you should have thought of that before you walked out of dental school, $400,000 net. I mean, if you didn't like root canals, you should have been an electrical engineer and worked at Intel. But you're a doctor, and they're coming in pain. And imagine if you went to the hospital and you said, I broke my leg, and the hospital said, oh, well, we don't do legs. Yeah. We don't do legs. We just do arms. It's like, what? I mean, you're a doctor. They got a toothache. Fix it. Either pull the damn thing, do a root canal, and if you pull it, maybe you'll replace with the implant. But that's where all the serious money is. And if you don't like surgery and blood and guts, well, for one, you shouldn't have became a doctor. I mean, what do you think I was? Intel inside? What do you think? You carve me open and find some Intel Pentium chips? I mean, we're filled with blood, goo, fecal matter. I mean, that's doctor stuff. This is Dentistry Uncensored, so I want to throw you under a bus right now and get you in all kinds of trouble. Basically, there's how no one agrees with their parents. Everybody thinks their grandparents are crazy. I'm normal. Like my grandparents, my parents are batshit crazy, and so are my children. I'm the only normal one at a Farran family reunion. But the older guys, almost everyone that's placed 5,000 to 10,000 implants in their life does them all freehand. And then all the millennials say, oh, no, you got to have a surgical guide. And it's like, well, how many have you placed? And they're like, I've placed 13. So a lot of the older guys tell these kids, it's like training wheels. The faster you get them damn training wheels off, you got to be a surgeon. You need to learn how to lay a flap, look at the ridge, treat complications, throw them damn training wheels away, and start doing it freehand. But it's a huge debate, and it's a huge controversy to surgical guide or not to surgical guide. In fact, I'm willing to bet your first 10,000 implants weren't done with a surgical guide.
Oh, not at all. And we even teach doctors not to use a surgery guide because you develop skills by doing it freehand. Now, some cases you definitely do need a surgical guide or would be better, but not every case. If you look at some of the studies, Howard, 38% of implants are pushed to the buccal with a surgical guide when it's done flapless. So now what we see is doctors want to do a surgery guide, they want to do it flapless, and that's not the best way to do it. Definitely early on your learning curve, you need to be able to open that tissue up, look at the bone, look at the angulation, and that's where you develop your skill sets.
There's also, I got to go back, you used a term, I always circle words that you use that I know some kid in dental school doesn't know what that means. You use the term platform switching. Can you go back and explain to that kid what platform switching is? You said that Jack Han, he started the replace implant with OBioCare, and it had platform switching. So explain platform switching.
Yeah, so if you look at the latest studies now, the best type of implant is going to be a tapered implant, which Jack was far ahead of the game on that, so he had that. And then secondly, platform switching, which means the neck of the implant is narrower than the body. Normally, when you place an abutment or the post on the implant, it will be the same diameter as the implant body. For instance, if you have a 4mm implant, you have a 4mm abutment that goes onto that. What platform switching does is it has a smaller abutment. So basically the connection is not at the same level as the implant and abutment connection. So the theory being, when you have the same size abutment, same size implant body, you have a micro gap there that harbors bacteria, and that can cause peri-implant issues. With platform switching, because the connection is away from the top part of the implant. Less bacteria is there. Also, you get a better seal, thus less peri-implant disease with those type of implants.
And talking more about PeriImplantitis, how come these kids can buy implant prosthetic cement with an ADA seal of approval, yet if there's any excess flash on it, it's toxic and can cause PeriImplantitis? I mean, how do you actually make a dental implant cement when it's actually excess is toxic? And then that brings up the bigger question, to cement or screw. Are you a cementer or a screwer?
Screwer now. Actually, the profession is really getting away from cement. I know that's a lot different than when you went through the program, and I mean, we cemented almost everything in the past, but now the profession is definitely going to screw retained. The problem with cement is you have to be very, very careful. You can get the cement down in the sulcular area, and it's very difficult to see. People say, well, take an x-ray, but you can't see it on the buccal or lingual, and only on the mesial and distal, a part of the mesial and distal, you'll be able to see it. So, I mean, if you look at Wilson's study, showed that 80% of peri-implant disease was caused from retained cement. So it is definitely a problem out there.
Another one is, this is very confusing. Okay, so you extract a tooth, and they just want to extract it for now. But the doctor's thinking, okay, I'm gonna bone graft this. The question remains is, number one, the bone grafting. I mean, that stuff's more per gram than cocaine or heroin, according to Ryan. And and then so there's cheaper ones. So it's very expensive. But the other question is, how long does it last? Because some people are saying, well, if you bone graft that extraction site and they don't get an implant for a year or two, you wasted your time. So talk about those questions.
Well, Howard, the way that we teach this is the number of walls that are remaining. So if you have a 5-wall defect, basically you have the buccal plate in all the walls after the extraction, meaning you take out the tooth cleanly, you have all the walls surrounding that defect. And a lot of times, no bone graft material will do just as well as putting bone graft material in. Secondly, you have to determine what type of bone graft to put in. There are so many different types of bone graft material. That's why I just wrote an article in the Glidewell magazine listing all the bone graft materials, because everyone is so confused on what you should use. I mean, do you use a xenograft? Do you use an allograft? Do you use an alloplast or an autograft? So you have to determine, ideally, you don't want a bone graft material that's going to resorb too fast, and you don't want one that's going to resorb too slow. So the bone graft material that we advocate now is a corticocancellous mineralized allograft with about a 250 to 1,000 micron pore size. That is about the best material that you can do now for a bone grafted socket. However, you have to take into consideration a lot of extractions will remove the buccal plate. When you remove the buccal plate, now you have a huge problem, and you have to place a longer acting membrane in there because you have to build that whole buccal plate back up prior to the implant being placed. So that a 4-wall defect, and we have a recipe for that with a longer acting collagen membrane that we place along with that bone graft material.
So we have an autograft from one part of the body to another, like a trunk or an arm. We have an isograft between genetically identical individuals, a monozygotic twin, or within an inbred strain. When they say inbred strain, does that just mean my family in Kansas, or is that, an allograft between different members of the same species, and then a xenograft between members of different species, like a monkey? And it's so what do you think? So what do you think's the highest? What's the highest quality, lowest cost?
Okay, first, the lowest cost would be an autograft. The advantage of autograft is it heals by osteogenesis, osteoinduction and osteoconduction. That is the ideal bone graft material. However, a lot of times it's difficult to obtain, so you usually have to go to a second surgery site.
Well, what about Megagen's new pulverizer, where you take the extracted tooth and have you seen that?
Yes.
Where you take the extracted tooth, you put it in, it looks like a garbage disposal thing, just purifies it to mush. What do you think about that?
But the Denton grinder, I don't have a lot of experience with that, but my question would be, number one, you can't use it with a tooth that's been root canaled or has large restorations, anything like that, or that's been infected. My question is, you grind this dentin up and you put in the socket, how long does it actually take to resorb? The goal is for you to get new bone growth in there. So that means that dentin needs to be resorbed and new bone needs to be formed into place. In the studies, I just don't think are out there yet to 100% support that.
Do you think they stole that idea from the last scene in the movie Fargo, where she put her husband in the wood chipper?
Yes, yeah, that's what it looks like. That's what it looks like.
I told them when they came out with it, they should call it the Fargo machine, and then have the picture. Was it a man or a woman with the legs stick out? Do you remember that scene?
Steve Buscemi's character.
Steve Buscemi was in the wood chipper? Yeah. Oh, yeah, that was the greatest. That's one of the greatest scenes of one of the greatest movies of all time, with his legs sticking out of the wood chipper. When I saw that thing, I just said, you should call this the Megagen Fargo wood chipper. And then the other question is, how long do you think those last?
Well, it all depends on, there's a lot of factors. And, generically, people like to say, okay, this is the best material, but it depends on the actual situation. You mentioned allograft. Allograft is probably the most utilized bone graft material now. That's basically cadaver bone. And there's mineralized and demineralized. Most people now use mineralized, but still xenograft, which usually comes from another animal. Some people still like that. And some people still use alloplast, so it's all over the place. And like I said, that's why I wrote that article, to kind of go over the advantages and disadvantages of each one, because it is so complex. When at the Misch Institute, what we do is we come up with a recipe and a protocol for each situation. So depending on where the location of the graft, depending on how many walls, depending on the blood supply, things like that, we will differ on our recipe for the bone graft materials.
Again, it's Dentistry Uncensored. I'm trying to get you in trouble. You're not going to be able to make everyone happy. There are some famous people out there that swear that with bone grafting and everything, you got to draw blood, you got to centrifuge it, you got to do these platelet-rich plasma involved. And then there are other people that say that you don't have, that's just voodoo. There's no studies that say that that's even worth your time. So PRP, to draw blood, centrifuge, is that going to increase my implant success rate?
Yeah. Well, I tell you what, Howard, we've been teaching platelet-rich plasma, or what is now called platelet-rich fibrin, for over 15 years. In fact, our third course, we teach doctors how to draw blood, spin it down, and how to utilize it. I believe there is definitely benefits with that. What I have seen clinically myself is better soft tissue healing with that. But people take it to the nth degree. They will be spinning down their blood, and they'll put it into an extraction socket, and they'll think that's going to grow bone. But if you think about it, how long does PRP or PRF stay around? It's usually a week or two. So how would that ever, it might help with the initial healing, maintaining the blood clot there, but to just put that into an extraction site, or some people advocate just putting it into the sinus, with no bone graft material, and it magically regenerates new bone. I think that is kind of far-fetched. But we use it as a membrane. We also use it to add into our allograft bone graft material, because studies do show it does help with healing and you get better quality of bone.
Man, we're already 17 minutes into overtime. Are you still okay? I still haven't finished all my questions. You're still good?
Sure.
Thank you so much for going. So is it just, should we just all quit ever saying platelet-rich plasma and PRP and just only use the terminology platelet-rich fiber and PRF?
Yeah, PRF now number one, it's easier. The technique, basically you just draw the blood. You don't need any anticoagulants or coagulants to utilize for the final product. Basically, all you do is draw blood and spin it, and it has 3 layers. You take the center layer, which is the PRF layer, and then we modify it to use as a membrane and to use in our bone graft material. So, yeah, I definitely think there is a place for it. Does it need to be done on every case? No. If you have a 5-wall defect for an extraction site, there's certainly no reason you need that. However, if you're trying to build a large area of bone, regenerate new bone, it probably is a good idea to do it.
So then it sounds like officially that you might be a vampire. Do you only place implants in the dark? That's my next question.
No.
By the way, do you know why they spell dark with the letter K and not the letter C?
No.
Should be good.
Because you can't see in the dark.
Oh, I like that.
You
That's
like
good.
that? No, that's it. Is that a dad joke or is that a grandpa joke? I mean,
I like that.
Is it beyond a dad joke? Yeah. Okay, again, I'm trying to get you in trouble. I just want to talk about the things. I never want to talk about anything everyone agrees on. I want to talk about what everybody disagrees on. And this next one's a very emotional deal because I'm talking to a dentist and everybody listening to you right now is a dentist. So it's kind of like, imagine that everybody listening is a Christian, and then I'm going to say something that, no, you should be a Hindu or a Buddhist or a Confucius. So I got buddies in town, in Phoenix, that are rhinologists. They don't like you guys doing these sinus lifts. They don't like it. They're like, dude, you had a bicuspid and a second bicuspid and a second mole. You had 2 rocks sticking out. File down the damn enamel to a bridge. Because they're saying that there's Americans coming into their practice often that thought they had allergies for 20 years. Turns out it's a slowly leaking, failing root canal. And they go up there, and that whole sinus is covered with white candidiasis and fungi, and this person has had a checkup at the dentist every 6 months for 20 years, and they extract that tooth, and the lady's like, are you kidding me? That was all from a tooth? And they're saying the same thing with sinus lifts. They're saying they have people come in there, and there's some implant sticking into the sinus, the whole thing's gone crazy. And you ever get, and in fact, Ryan, we got to get Jason Hill, email Jason Hill to get that buddy. I've been on him to make he's a rhinologist, to make us an online C-course, so that your ENT buddies say, dude, so here's the deal. Dentists worship at the altar of enamel, and they think tooth is sacred, and they don't want to file down any enamel, but shit, they'll throw a hand grenade in a sinus and pack it with dead cow bones and paper clips and hormones and all this stuff like that. And the ENTs are the opposite. Their god is sinus. They're saying, dude, stay out of my sinus and drill down those damn teeth. So you have no respect for the sinus, and the ENTs have no respect for the enamel. Which one's right?
Well, I mean...
And also, wasn't that a big reason Allon4 got so popular? Because you could stick 2 implants behind the sinuses, 2 in the front, and one of the popular things about the Allon4 is you don't need any sinus lifts.
Yes. So if you look at Howard, one of the most predictable areas to grow bone is the maxillary sinus. It's very, very predictable. Why you see problems, and that I probably read the ENT literature more than the dental literature because my area of interest is the sinus. I do a ton on pharmacology. I do a ton on pathology. If you look at that textbook, there's probably 30 pages on maxillary sinus pathology. The problem is, and we spend almost a day on it at the Institute. The problem is that a lot of dentists violate the maxillary sinus without determining if there's pathology in it. I've done probably 3 studies with residents at the University of Temple perio department, and about 40% of patients who are asymptomatic have pathology in their sinus. My study's almost 18 years now. I'm about 39% have some type of pathology. So there is a disregard for determining if there is pathology. Secondly, you must determine if the ostium, which is the opening which everything flows out of the maxillary sinus, is patent, meaning is it open or not. So people always ask me, well, how far can you stick an implant into the sinus without it causing a problem? You can stick an implant 10 millimeters in the sinus. There's pathology in the ostium is patent, going to most likely have a problem. However, if you have pathology there, you bump up that membrane a half a millimeter, and you're going to change that whole physiology of the sinus. And the problem is, and why the ENTs get upset, is the paranasal sinus is the ethmoid, the frontal sinus, and the maxillary sinus are all interconnected into what we call the osteomeatal complex. So if you just push an implant a half millimeter into the sinus and you cause a maxillary rhinosinusitis, that secondarily affects the ethmoid and or the frontal sinus. So that's why they're uptight about, what is happening. Now, on a second point, you talked about a tooth that was causing problems in the sinus. What is interesting in the ENT literature is 15 years ago, it was always thought that odontogenic origin of rhinosinusitis was about 10%. The latest studies are showing about 40% of chronic rhinosinusitis has an odontogenic origin. So what does that mean for the young dentist coming out? When you see a patient, you get a CT scan, you have to learn what is sinus pathology and what's not, and to be able to evaluate if a tooth is causing that infection. I mean, the maxillary molars, Howard, you're looking at over 40% of the mesiobuccal or the lingual cusp is in the sinus in the first molar region. So that's pretty significant to cause some type of sinus pathology.
I told you a really bad dad joke that there's no seeing dark. I want you to put your dad hat on. She graduated from dental school last May. She's working for a DSO, and she's looking at this molar. It's a failing root canal, and she just wants, how does your amazing mind work about sending that to a endodontist and do a retreat, or just treat that damn thing with forceps and do an implant? What are you thinking when you're grasping with that issue?
Well, now I look at the costs involved and the long-term prognosis. We always look at the tooth. How is the 5-year prognosis? If the looks of that tooth means that in 5 years, that tooth is most likely not going to be there, we take that out because it is definitely more predictable to put an implant in a freshly healed site with no pathology. Doing an apico, the studies are all over the place. I mean, the funny thing is, Howard, you wouldn't believe how many endodontists we're getting now. We had 3 endodontists at our complication course.
Well, you know why I think all the endodontists should do it? You know why I seriously do?
Why?
Because, the people don't stop and realize, first of all, these dentists think they can't sell an implant case. Well, the average price of a new car in America is $33,500 according to Kelley Blue Book, okay? The average American will buy 12 new cars in their lifetime. So if the average new car is $33,500, what percent of the dentists in America, those 125,000 general dentists in America, last year, what percent did not sell one single case that was worth $33,500? What percent?
Oh, I have no idea.
95%. And when anybody tells me there's no money in Toledo. That's why Klinger dresses up like a girl. There's just no money there. And it's like, really? Well, the average person in Toledo will buy 13 cars in their lifetime for $33,500, and you never sold one $33,500 case in your whole life. Reason the average American buys 13 new cars. We were talking about the endodontists in your program. The reason
Yes.
the average American buys 13 cars in their lifetime because the average woman lives to be just about 80, average male 74. Men die 6 years earlier than women because we're married and want to die. And so you buy your first car at 16, you're buying them until you're 80. They're financed at 5 years. You're never going to sell an implant case if you go in there and say, give me $33,500. You got to go in there and say, hey, my God, Randolph, you got great credit. You've been approved. Your payment will be, and 33,500 without interest divided by 60 months, you're looking at $558 a month. That's how all the big boys sell their stuff. So I go back to those endodontists and I say, well, dude, when you buy a car for 5 years, the reason the banks will finance it for 5 years because the damn car lasts 5 years. And I sent you a failed root canal and you took $1,500 from grandma, and 6 months later we pulled it. Now you're going to give her $1,500 back? Well, I did the best I could. Bullshit. That's the only way you can feed your family. So you get 8 people a day, and you know that too, that retreat's not going to work. You know that tooth's dry and brittle. You know she's 80 years old. But you do it anyway, because if your only tool is to hammer, everything looks like a nail. So I tell them this. I say, you either warranty the damn retreat for 5 years, or you learn how to place implants. And I know that you looked at this because the basis of the only thing every major religion has in common. My oldest sister's a cloistered Carmelite monk for 35 years. The other one's Immaculate Heart of Mary. But my oldest sister speaks multiple languages, has read every major book from Hinduism, Buddhism, Confucius, Christianity, Islam, Judaism. She said there's not a person, place, or thing that's in all these major religions except for one thing, the golden rule, clear as a bell, treat other people as you wanted to be treated. All the rest is commentary. All the rest is noise. Just treat other people like you want to be treated. Well, that endodontist is looking at that failed root canal and he thinks, well, I could do a retreat or an apico or whatever, or I could pull it and do an implant. They're both $1,500. I think I'm going to go there. I trust that. What I don't trust is an endodontist who can't place an implant and doesn't warranty his work. So either start placing titanium or start getting 5-year warranties, because I think it really hurts the business. I mean, Americans wouldn't buy 13 new cars in their lifetime if 20% of them were thrown away after a year. I mean, they wouldn't trust it. The only reason you buy a new refrigerator, a new dishwasher, a new car is because you really think you can take it to the bank, it's going to last 5 years. And that's what I do to my associates. Someone snaps their tooth off at the gum line. So they'll do a root canal build-up and post-build-up crown and charge out a root canal build-up and crown. Well, hell, in 6 months or a year, she's going to walk in and hand it to you. Well, we warrant everything 5 years, buddy. So I'm going to credit all that towards the implant in the crown or the 3-unit bridge because it didn't last 5 years. End of story. And if you start making your associates start treatment planning to everything lasts 5 years, they stop being little hero-dontists, because it's easy to be a hero-dontist with someone else's money. But be a hero-dontist with your own damn money. Oh, and by the way, I didn't finish with that sinus deal. I want to finish that sinus lift deal where you said you read more ENT. Some people are shamed on Dental Town when they do a 3-unit bridge. I mean, they're shamed, like, you hack, why did you file down those teeth? They were virgin teeth. When people start saying teeth are virgin, first of all, teeth don't have sex. I've been around 55 years. I've never caught a molar hump in a bicuspid. So when you're calling a tooth a virgin, at what point are you an emotional whack job? But I just want to say this. Again, she's sitting there in Salina, Kansas, and a bridge or an implant in a crown, is she a hack for doing a 3-unit bridge, or is that still a viable treatment plan?
No, I mean, Howard, I truly believe that the dentist should give all the treatment plans to the patient, the advantages and disadvantages, and not you know, if say you were talking about the endodontist, well, they do the apicos. Someone should tell that patient another option should be an implant, and you owe it to the patient to give all the options. So a 3-unit bridge, is that below the standard of care? No, not at all. You know, you have to evaluate, say, if you're missing the upper left first molar and you have very little bone. Is it worth it to put through the patient through a sinus graft and an implant, or just a 3-unit bridge? So there's advantages and disadvantages to every situation. And I believe that, you know, for the young dentist, if you want to be a good, productive dentist, you give them all those options. And then let the patient select from those advantages and disadvantages what the best course of treatment would be.
Okay, and I promise, I swear to God, I'm wrapping up. I know we're an hour and a half, but same question with mini implants. I mean, let me tell you how crazy Dentaltown is. Under implants, we had to separate implantology from mini implants, because every time someone would place a mini implant deal, all these religious freaks would get on there and say, oh my God, mini implants. I mean, 3M, and that's another question. Why did 3M buy Imtech in 2008? And why did they stop selling implants? Do you know why 3M did?
I have no idea, other than maybe I don't know. I don't know.
I don't know either. And it's a closely guarded secret. But hell, even 3M quit selling mini implants. I mean, we basically had to tell. On Dentaltown, we play 3 strikes and you're out. You know, by the way, if you see something on Dentaltown and you don't like it and it makes you feel bad, hit the report abuse button. We got a dozen dentist volunteers. And I know some of you are all butthurt that, you know, some of these people have been kicked off. But you know what? I get enough stress from insurance companies, staff, patients, Ryan, you know, all this stuff like that. Ryan, why do you even take this job? All I do is abuse you during the whole show. But Dentaltown shouldn't be a place where you get abused. And if you can't, you know, and then they say freedom of speech. Dude, freedom of speech is a constitutional right between you and your government. Dentaltown is my house. It's my private property. You have the freedom of speech, but you walk in my house, I'm going to blow your head off. And if you go to my house on Dentaltown and you start making people feel bad, I'm going to warn you once, I'm going to warn you twice, and the third time you're going to be banned. And but anyway, we had to separate the mini implant discussion.
Oh my God.
Because there's all these purists that think mini implants are below the standard of care. So what's your thought on a mini implant?
Well, as you know from going through the Institute many years ago, we do still teach mini implants as a temporary, such as, you know, you're doing 3 or 5 implants on the lower and you use it to stabilize the denture, but not as a long-term treatment option. And, you know, Carl always used to say, well, if you start to do implants, you need to move your office every couple years or it'll catch up to you. And I think the morbidity of mini implants is just so high, it's not worth it. And there's too much stress in a private practice to deal with that. So, yeah, I don't advocate them for final prostheses, definitely.
Okay. So your website that you're all this on, would you recommend them going to misch.com, or did you want them to go to your resnikdentalimplants.com? Which one?
Misch.com has everything.
And then what is the resnikdentalimplants.com?
That is just private practice.
You know what I wish all the implants would get shorter and fatter, because I'm for anything that's short and fat. I mean, I'm 5'7", 220. I want to be the poster child for short, fat implants. And that's another thing. When you and I were little, it was the longest implant we could get. It was doing everything. Can we get 14, or can we get a 16 millimeter long? Or, oh my God, I think we can get an 18 millimeter long. And now the trend is these implants are getting shorter and fatter. I mean, I always assumed shorter and fatter was a good thing. Is it?
Yeah, actually, if you go back to one Carl's master's thesis in 1988, he did 3-dimensional stress analysis on the biomechanical force being put on an implant. And what it basically showed is the forces generated around the neck of the implant, very little goes to the apical area of the implant. So why do you need a longer implant? for stabilization, but if you have good quality of bone, you certainly don't need a real long implant anymore. The studies are definitely pro shorter implant.
Pro shorter implant, but also wider, fatter, right?
Wider, yes, wider. I mean, if you go from a 4 millimeter to a 5 implant, it increases the surface area by 30%. If you take a 4 millimeter implant, just add 2 or 3 millimeters to the apex, it increases only by 10%. So the surface area increases dramatically.
You know what would be the best marketing for your book, even though you don't need it at all? And we push it out today. Right? We posted it on Dentaltown, Facebook, Twitter, Google+, Instagram, Pinterest, and LinkedIn. But I wish, just to give some massive credibility to Dentaltown, if you wrote us an article for Dentaltown Magazine, it's mailed to 125,000 general dentists every month. And if you created an online CE course, the millennials, I'll tell you what, if you look at these meeting attendants, they're all drifting downwards, and they keep asking, why do millennials not go to all these brick and mortar meetings? Dude, we put up 415 online courses on Dentaltown. They're coming up on 1 million views. So the millennials, they open up the online CE course on Dentaltown, which costs probably less than the Uber ride from the airport to the dental convention. And then they have Apple TV, so they throw up the course on Apple TV. So now they're sitting in their favorite chair at home, I assume drinking wine and eating popcorn, watching these lectures on their big screen. And I would just, oh man, it'd be so awesome to get you to do an online CE course. Ryan, will you send them both, him and Howard Goldstein? I'm Howard Farran, so I'm Howard at dentaltown.com. But the guy in charge of the online CE is Howard Goldstein, so he's Hogo, H-O-G-O at Dentaltown. He's in Bethlehem, Pennsylvania. I think he moved there because he thought that's where Jesus was born, but I told him I'm pretty sure it was a different Bethlehem. But anyway, would you ever consider doing an article?
I would love to.
Oh, man, I would love it too. But my gosh, you promised me an hour of your life, and I stole an hour and a half. I want to tell you, man, I could talk to you for 40 days and 40 nights. Loved your book, loved you. I've seen you lecture so many times over the years. Just thank you so much for coming on the show today and talking to my homies for an hour and 40 minutes.
Great. Well, thank you, Howard.
Well, the pleasure's all mine. Thank you, Ryan.